Hi, good evening. I'm Scott Succo, your Executive Director of the Liver Coalition of San Diego, and welcome to tonight's Liver Q&A. Before we get started with some introductions, I want to do some housekeeping on how you can get the most out of tonight's webinar. First off, we'll be fielding questions throughout the webinar and then also at the end. So you'll notice that there's a question box or a chat box, and our moderator will be pulling those out and then asking them throughout the presentation. So if you've got a question, please put it in the question box or the chat box, and then that way we'll get it. At this time, I'd like to introduce our board president, Terry Cunningham. Hey, Terry.
Hi, Scott. I'm turning on my, welcome everyone. Very happy to have you here this evening for our next webinar in the series that we're doing on education about liver diseases. The Liver Coalition of San Diego was started last year after the American Liver Foundation decided to close its district offices. And we felt that there was a need here in San Diego, and so we formed the nonprofit Liver Coalition of San Diego. And all of our funding that we receive, all of the money that's donated, stays here in San Diego, unlike with national organizations where it goes to the national headquarters and then is divvied out to the the subsequent organizations. So any donation that you make will definitely stay here in San Diego County. We're very pleased with this series of seminars, and if you have not seen all of them, they are available on our website, and we suggest that you take a look at them. They're extremely interesting, and we have another interesting one this evening. And I will turn the microphone over to Shirley Sunita to introduce our presenter. Hi, Shirley.
Hey, and Shirley, I missed my spot. So if you would allow me to thank the sponsors.
Absolutely.
And sorry about that, Terry.
Oh, sorry.
And then I'll bring it over to Shirley. Tonight would not be possible without our sponsors, and we wanted to take a moment and introduce them and allow them to say a few words or some to show a video. And our first sponsor is Esai, and Lori will show a video that they've prepared for us to as one of the sponsors for tonight. Excellent. Thank you, Esai, for being here and making it possible for us to do these liver Q&A webinars. Our next sponsor is Gilead, and with us tonight from Gilead is Greg. Greg, would you like to say a few words?
Yes. Hi, Scott. Thank you for having us tonight, and thank you for these great webinar events. And Dr. Gish is a world-renowned speaker, and it's always a privilege to listen to him. So thank you, Dr. Gish, for doing this talk tonight as well. Happy to be here.
Thank you.
Great. Thanks, Greg, and thanks, Gilead. And now back to the program. So Shirley, thank you so much. And our moderator for tonight, I'm Shirley. Thanks, Shirley.
Hi, everyone. I'm Shirley Tsunoda. I'm a professor at the Skaggs School of Pharmacy at UC San Diego, and I'm also one of the co-chairs for the Associate Medical Advisory Committee of the Liver Coalition. And it's my pleasure tonight to be the moderator for this talk. So if you have any questions, feel free to put them in the chat, and I'll be monitoring that. And we will ask Dr. Gish your questions as we go along. Or if you want to save them till the end, that's fine as well. So I'd like to introduce tonight's speaker, Dr. Robert Gish from La Maestra. And as someone previously already said, he's a world-renowned hepatologist, and he's going to talk to us about Wilson's disease. Dr. Gish.
Thank you, Shirley. Thank you, Scott. Looks like my video is now working and you're seeing my full screen. Is that right?
Yep, we can see it.
Fantastic. Oh, I'm just going to go to the other slide deck. Just give me 2 seconds. Excellent. All right. So we're going to talk about Wilson disease, just to remind everybody that Wilson doesn't have an S on it. No, not possessive. It's defined by this wonderful researcher who we'll talk about shortly. But I thought we would start out with a case presentation. And this is real life. This just happened a couple of months ago here in San Diego. There's a 40-year-old Burmese man, actually, I think he's Karen, who presented with hyperbilirubinemia, jaundice, elevated liver enzymes to our clinic. We sent him to the emergency room, and we'll talk about that progression in just a moment. He has a history of having a COVID infection that was moderately symptomatic in August of 2020, hyperlipidemia, vitamin D deficiency, but no history of NASH, normal body mass index, or just slightly elevated at 24 for an Asian. So in September, he presented with jaundice, right upper quadrant pain, dark urine, yellow eyes, oral mucosa, and had no history of IV drug use, no alcohol use, although he'd been drinking this Myanmar tea, some unknown type, and using Tylenol sparingly. He had liver imaging and a liver biopsy. There was no evidence of biliary obstruction. Blood tests for autoimmune hepatitis were negative. A, B, C, E were all negative as well. Had a hepatology consultation at UCSD and was diagnosed with drug-induced liver disease from this tea, but no clear culprit was identified. He was asked to avoid herbal supplements, was discharged home, and labs just a few days later showed liver enzymes that were better in the 40 to 80 range, alk phos normal at 94, but his bilirubin was 14, mostly direct bilirubin, indicating abnormal liver function. He was seen at our clinic after discharge. We still were concerned about alcohol use. They may have been hiding that, so we did what was called a PEth, phosphatidyl ethanol, PETH. And we said, this is really strange because this patient had a really high bilirubin, but normal alkaline phosphatase. And that's a classic presentation for Wilson disease, although Wilson disease in Asia Pacific region is not well described, although in China they've been describing more and more cases because they've been working up people for diseases other than hepatitis B. He had a ceruloplasmin that was performed, liver biopsy was sent for liver copper quantification, he was sent for an eye exam for what are called Kaiser-Fleischer rings, and then eventually had genetic testing for Wilson's disease as we worked through this, although all this laboratory testing took place over about a month or so. Here's some laboratory tests just to show you. His hepatitis workup was negative. His hepatitis A antibody, including IgM, was negative. Core antibody was positive, but IgM was negative. So he'd been exposed to hepatitis B in the past, but surface antibodies positive. So we call this immune controlled. Surface antigen was negative, HIV negative, and of course we did an HBV DNA because some of these patients can be DNA positive and surface antigen negative. Hepatitis E IgM was negative, also negative autoantibodies, as you can see, and the urine copper was elevated, so over 35 is abnormal. He was 92, and liver copper was elevated. Now 112 is a bit of what we call a gray zone. Over 250 is typically diagnostic for liver copper, but less than 35 is normal. So it's kind of nice, the urine copper 35, liver copper 35, gray zone up to 250 for urine and liver copper. That's how I remember this kind of simply. And look at his ceruloplasmin. We ordered it twice. It was absolutely normal, 31 and 47. So this is still a little bit interesting because the ceruloplasmin is normal. It's a blood test typically that's low in Wilson disease. I've seen as low as 2 or 3. But most Wilson patients are in the 8 to 15 range. But 5 to 10% can have a normal level of this protein that's involved in copper assessment. And also the urine copper's in the gray zone, the liver copper's in the gray zone. So we definitely decided to move forward with this genetic testing, which is a little bit difficult to get. You have to get authorization. It goes to an outside lab. It takes a few weeks. And he had two different genes for Wilson disease. It's called a compound heterozygote. And of course, they came up with likely pathogenic. So we had a urine copper suggestive, a liver copper suggestive, and now we've got two different genetic mutations that were positive on this case, even though the Kaiser-Fleischer rings were negative. He had no neurologic signs of copper overload that you can see. He had no acidosis. Some of these patients can present with what's called a renal tubular acidosis. They can present with a low phosphorus. They can present with a low uric acid. He did not have some of these classic signs that we see in some of our patients. But what we did is we obtained Triantine for him, and we did get another urine copper just before starting treatment, which was 33. 1 week later, after being on Triantine, his urine copper is 2,800. This is extremely high and classic for Wilson disease and decoppering that took place. What was really, really nice about this, he was jaundiced, feeling terrible, fatigued, bedridden at home. And you can see by January 6, 2021, his total bilirubin is 0.7, and in February, 0.5. So this is a absolutely miraculous response to Triantine and also absolutely diagnostic for Wilson disease. Prior to that, his bilirubin was just basically moving sideways for over a month while we're getting this whole workup done. And of course, we were concerned he was going to go into liver failure. So quite an interesting case. We are constantly in contact with the UCSD team, constantly in contact also with Michael Shilsky at Yale, who basically I present all of my cases to and keep in touch with him because he's always teaching me about Wilson disease. So let's take a quick look and talk about Wilson disease. This is a disorder of copper metabolism where there's too much copper in the liver, and then it gets deposited in the brain and the heart and the pancreas and the skin and joints and cartilage and this eye that we talked about. And the liver biopsy can look like autoimmune hepatitis. It can look as fulminant liver failure where the liver just collapses. And it can present, of course, with chronic liver disease, present with cirrhosis. So 1 in 30,000 people have this homozygous, or what we call it, in this case, a compound heterozygote. The carrier is about 1 in 100 people. It is actually higher in China. Once they started looking for this disease, they found it. I've seen it in Vietnamese patients before. Now we have a patient from Myanmar who has it. It's really important to be thinking about this diagnosis. And as I presented, this patient had a bilirubin of 14, but alkaline phosphatase, which is another key liver enzyme, it was absolutely normal. So this is what happens in a board test. This would be a great one for your gastroenterology, hepatology, or even internal medicine boards that doctors would need to pass. So this copper can lead to all sorts of brain problems and thinking problems. It can result in a heart swelling and the heart not conducting electricity. It can hurt the kidneys and cause what's called too much acid in the body, low phosphorus, low uric acid. People who present with acute Wilson disease, this is where they may develop liver failure in really rapid order, typically have hemolysis, where the red cells are fracturing and have a profound anemia. People can get osteoporosis, they can get joint pain and arthritis and arthropathy. So this is a systemic disease of accumulating too much copper. I'm not going to go through this slide because it goes into even more detail about where this problem with copper deposition can take place. They can have problems with what's called a parathyroid. So it can have problem with calcium and magnesium metabolism also. They can get these very interesting cataracts called sunflower cataracts. They can get skin changes and rashes. Women can have menstrual irregularity. There can be delayed puberty because of suppression of hormones from both the pituitary gland and also the other glands that secrete hormones in the body. So it's a very, very nice slide just detailing how much copper deposition can affect. Another really fancy slide that talks about copper, being taken up inside the intestinal tract, but it's in the liver where copper can't be secreted because of this protein that moves copper in and out of the liver cell. So the liver cell builds up copper copper spills out into the bloodstream and starts getting deposited all over the body in different parts. It can present as young as 8 years of age. I've seen, I think 8 was probably the youngest that I've seen, was a child from Costa Rica. It tends to present later with these neuropsychiatric problems, these problems of brain function. So personality changes, depression, psychosis. I had a patient, who's Vietnamese, who had catatonia, basically in almost a coma, and had undergone electrotherapy to the brain on at least 8 occasions. And they didn't figure out he had Wilson disease until he presented with an acute abdomen, severe abdominal pain. They took him to surgery, took out his gallbladder, and found the liver was cirrhotic and referred him for a liver transplant evaluation. So typically it's going to be less than age 55 years of age. Can have abnormal liver enzymes first, abnormal liver function later. We mentioned the best function test is bilirubin, super high bilirubin, but normal liver enzyme, which is the alkaline phosphatase. Hemolytic anemia, we talked about those already. So whenever people present with abnormal liver tests, cryptogenic disease, we're obligated to go down this route to order a ceruloplasmin at a minimum. If I'm thinking of ordering this blood test for this protein, the ceruloplasmin, I'm going to immediately order a 24-hour urine copper also, and then get a slit lamp exam for these KF rings. I just get all 3. It's just really simple. In my brain, there's really no such thing as cryptogenic liver disease. I don't think there's really ever any hidden form. So ceruloplasmin decreased this blood test in 90 to 95% of patients. 24-hour urine copper is elevated in most patients, although as you saw, we had one that was 33, that we put the patient on Triantine, and we call this a copper deloading test, and it shot up into the thousands. It's incredible. The liver copper was definitely abnormal, so we knew that we were going the right direction when we had that test back from that biopsy. And that biopsy that they performed at UCSD was critical to get that done and then get it sent off for the right tests. This is a complicated slide. I'm not going to go into it in great detail, but you can see right in the middle of the slide is something called molecular testing. So right now, the molecular tests do genetic sequencing. They're inexpensive. They're maybe running around $1,000 to get one of these tests done. But it's really critical to have that, because then we're going to go and test all of his family members. He's got 7 siblings. All those people need to have a ceruloplasmin done and a 24-hour urine copper. And we're not going to do genetic testing on everybody in the family. But if the ceruloplasmin's low or urine copper is high, then we're going to move to more advanced testing in the rest of his family. So this just goes back to, I said the 35 rule. Here it says 50, but this patient was definitely in the 100 range for the tissue copper. So it's definitely time to get the rest of that Wilson disease workup done. And yes, you're going to have to go through some work to get the genetic testing done. There's a pre-auth process. You're going to have to work with the send-out lab. Getting the tissue copper sent out too is a bit of a problem, because sometimes we send it for tissue copper and the lab goes, oh, what they really meant was iron. And then we get an iron test back and we said, no, we wanted copper. But the good news is the labs such as Mayo and other reference lab, when they get a copper test, they run copper and iron. If they get an iron test, they run iron and copper. Because they've had too many challenges in the past with errors, and they just decide it's easier just to get both tests done. Penicillin used to be the best treatment for Wilson disease, but it has so many problems, so many complications of rash, kidney problems, bone marrow problems, gastrointestinal upset. So really, Triantine is the first line agent. It's the only medicine I use. I haven't used penicillamine in probably 20 years. There is another drug, this tetrathiomolybdate, that's undergoing research and may be FDA approved in the US as an orphan drug. And then zinc is really interesting, because zinc competes with copper in the intestinal tract. And there was a man named Brewer, he used to work at the University of Michigan, but now he's retired as far as I know. He used to say, oh, we don't even need to use Triantine. We're just going to give everybody zinc. And there were some studies done at University of Michigan, some studies done also in Europe, that unfortunately ran into some problems because some people failed zinc and developed fulminant liver failure and needed a liver transplant. So you have to be very careful. What we like to do is decopper the patient with Triantine, try and get as much copper out of the body as possible. And that's easy to follow because every 6 months in our patient, we'll be checking urine copper. And as that copper level comes down to less than 100, we may be able to reduce the Triantine dose and then put zinc on board. And then eventually, by using zinc, we might even replace the Triantine. Although I tend to prefer both, use low dose Triantine because it has less side effects, and then use zinc to basically spare how much Triantine we give to the patient. Now, there was a really big problem because one of the pharmaceutical companies bought the rights to both penicillamine and Triantine. And this is probably 10 years ago, maybe 12 years ago, but the price for these two drugs went up to $250,000 a year because of a monopoly on the two drugs. This one company got the rights to both and decided they were going to take the price to the sky and that the insurance companies wouldn't notice. Well, two things happened. One, I can tell you of a specific case of a small insurance company that was basically self-insured in the Sacramento area that had a doctor who had 2 children with Wilson disease who needed to be on one of these 2 medications. And the insurance company went bankrupt because just 2 people on these drugs took basically all of their resources. Then what happened was a really good mobilization of the Wilson Disease Association in the US. They went basically after the pharma company and then went to Congress, and under, I would say, some indirect pressure, the price came down on these drugs substantially. And also the insurance companies became aware and did some also self-negotiation, I have to say, and got this manageable. So right now we were able to get Triantine for our patient. And I don't exactly know what the price was because it was a specialty pharmacy that has a contract with Maestra. But whatever the pathway forward was, and I want to thank Yanis, who works with me, and Adla Tessier, who works with me, to get this to the patient quickly. Because this patient, I was very concerned, was going to go into liver failure and need a liver transplant if we couldn't reverse the trend in liver function. Remember, the liver enzymes look quite good in this patient, but he was absolutely disabled, severe fatigue, jaundice, itching. And Triantine really came to the rescue once we got all of our ducks, our lab tests, and our genetic testing in a row. And it was the genetic testing that really sealed this case. But you have to be patient. You have to go through the pre-op process. You have to be tenacious. You got to fill out the paperwork. If it gets declined, you may have to call the medical director at the insurance company to get things pushed through. So he's doing well. Very happy. We're going to be actually having, I think, him go back to work at the end of this month. So here's just more side effects of penicillamine and Triantine. So you can see with D-penicillamine, adverse events and side effects were running in the 30% range. And then Triantine, about 7% range. So you can see I just go to Triantine since the pricing is the same. And I just have to worry less about monitoring the patient and giving them education. If you look way down on the bottom, this tetrathiomolybdate is here, and there has been some neurologic deterioration when you put people on this. It binds the copper, it's moving the copper, I guess, out of the brain, and by moving the copper, there may be some brain damage that would take place. There's been some minor issues of anemia, neutropenia. I haven't seen the full reports on whether it's liver toxic or not. Since these patients already have liver disease, that might be a little hard to sort out. Prognosis is interesting. So if somebody presents with fulminant Wilson disease, you basically have them to a transplant center on a transplant list. And unless they reverse quickly, you can consider plasmapheresis for these individuals in the hospital where we're taking out plasma and the copper toxin, trying to reverse them. But most of these patients do go on to needing a liver transplant. Although we had a patient recently in Las Vegas that I took care of, which is one of my practice locations, who had Wilson disease, who actually turned around with short course of plasmapheresis and then was put on a chelating agent. But in general, they don't recommend that if you've got somebody in the ICU with fulminant Wilson's going into a coma, that the chelating agents is really going to do much for those patients. It's really the patients in these gray zone, which more of a subfulminant picture, aggressive picture, but not really liver failure. And our patient, from a very important perspective, didn't develop any mental confusion, any encephalopathy, and his INR, the coagulation test, just changed slightly. His normal was about 1.0, and I think the highest it went was 1.2. So he did not fit the fulminant or even the subfulminant picture. He just presented with this severe cholestatic illness. And that may be something specific to the genetic mutations that he had. And who knows, the ceruloplasmin level was normal to slightly elevated. Maybe that ceruloplasmin in some way might have been protective for him, since ceruloplasmin is part of carrying copper and moving copper throughout the body. You really have to convince these patients not to go off their Wilson drugs. As I mentioned, I've seen patients in my practice who are stable on penicillamine or Triantine. They went to see a specialist. The specialist said, "Oh, we're going to just manage you with zinc, take them off the medication, not monitoring them, and then they go into fulminant liver failure and need a liver transplant." So I've seen one case of that also in the last 10 years. It's very depressing, because we really, if you're going to start changing their Wilson medicines, you really have to monitor them closely, potentially even weekly for a month or so, and then every 2 to 4 weeks for another period. So that's the short story on Wilson disease. Just to remind everybody, there's no S on Wilson. Wilson disease, like Gilbert syndrome, we're dropping the S's. There's no possession of these diseases. We did have a case question that came through from Sonia. Do we want to switch to that next, Shirley?
Sure, that sounds good, Bob. Do you want me to read you off the question? So this is a case of a 15-year-old patient who is potentially being diagnosed with Wilson's. And so one of the questions is, are AST and ALT ratios commonly used? I know you talked a lot about the bilirubin being very important, but what about the liver enzymes, AST and ALT?
Fantastic question. So this is a really good time to emphasize that alkaline phosphatase, GGT, AST and ALT are not liver function tests. There's even some junior and senior hepatologists out there that get really confused about this. And we're trying to change this terminology throughout the primary care community, to our pharmacy colleagues, nurse practitioners, everyone. Liver enzymes and liver function are in two separate buckets, and we really don't want to get those confused. We don't want them in the same bucket. So AST and ALT in this patient you saw were just slightly elevated. And the ratio is interesting, because if the AST is higher than the ALT, we actually use that to stage the level of liver disease. And I don't know if I need to actually show my screen right now, so we'll just keep talking. So if I see the AST higher than ALT, I'm really thinking that person has cirrhosis. Or in more rare settings, that AST higher than ALT may indicate alcohol abuse or alcohol-induced liver injury. But now you can sort out alcohol by taking a good questionnaire. And of course, we doubt this 15-year-old can have an alcohol problem. So if the AST is higher than the ALT in this 15-year-old person with possible Wilson disease, I'm going to think that they've got advanced fibrosis or cirrhosis. And all providers now, I'm saying all hepatologists, but all providers should look at that AST to ALT ratio in anybody with chronic liver disease. It's a great question.
Great, Bob, thank you. And then one of the other questions is, if an individual presents with neuropsychiatric symptoms of Wilson's disease, but their liver is otherwise fine, would you still consider a liver biopsy to be indicated?
Yes, so I think the liver biopsy is useful for two reasons. One, I want to get that diagnosis, and I mentioned that the liver tissue copper is part of that. Now, you could say, what if the urine copper is 1,000 and they have the genetic testing done and it's Wilson disease? I'm going to say liver biopsy may be a little bit optional, But let's go back to the first question. AST in this case looks like it's higher than the ALT. So I'm very concerned that the person may actually have cirrhosis. So I'm going to want that biopsy to stage and get a baseline copper. Because what I've done in my patients also is to get another biopsy in 3 to 5 years and make sure that they're completely decoppered before I'm going to switch them to a zinc monotherapy, which does happen in some cases. If you're in a developing country or a country where Triantine's not available or it's very expensive or it has to get shipped in, zinc becomes very optimal. But I'm not going to switch them to zinc until all of the copper or most of the copper is out of the liver. So I think a liver biopsy is very useful. Again, this is on a case-by-case basis. It looks like from that part of the first question too, Shirley, it said, what if the AST and ALT are in the normal level? Would that ratio still be important? Well, we have to remember what is normal for AST and ALT and what is healthy. The labs typically say 40 or 45 is normal for an AST and ALT, but we know in a woman, an AST and ALT should be less than 25, really less than 20. And in men, it should be less than 35, less than 30. So I still think the ratio is going to be useful, even if it's in the normal range. But I'm definitely going to ask to get elastography, get one of our special scans on these on this liver. I'm going to look at the liver portal vein diameter. I'm going to look at the spleen size, see if it's a big spleen or not. All that's going to help me assess this patient. And as I mentioned, if I think someone's got Wilson disease, I'm going to look at renal function. I'm going to look at bone health. I'm going to look at a phosphorus level. I'm going to look at uric acid level. These are all blood chemistry tests that are very inexpensive, but it's a way to look across the patient. I'll get an EKG. I'm going to see if there's too much copper in the heart. Is there a conduction defect where there might be something called a prolonged QTC? I'll look at calcium levels. I'm going to look and see if they have diabetes, see if there's any evidence of pancreatic dysfunction. Might get a parathyroid hormone level in these patients. We really got to look across the whole body where copper could be causing damage.
So it sounds like, based on, all of those tests you just mentioned, that the liver biopsy is not necessarily a gold standard. Is that accurate, or would you consider it still a gold standard, I guess, for assessment of the liver itself?
I'm going to call it gold, not quite platinum, and I'm going to be thinking about it in most cases. This case is very special. It looks like normal enzymes, but classic neuropsych cases, and has got the genetic mutations, right, that look like were diagnostic for Wilson disease. So there is a woman in Canada, who I think's in either Calgary or Edmonton, that is one of the best Wilson experts in the world. And I can get that name to the team. I'm just blanking on it for the moment. It's a Canadian
And I have
question, right?
I do have another question. We don't have any questions right now from the audience. So audience, feel free to put questions in the chat if you have one. But I do have one for you, Dr. Gish. So in these patients who you treat with Triantine and then zinc, we haven't corrected their genetic abnormality, right? So do they have to be on medication continuously? Do you need to monitor them in the future, that in case they start to build up the copper? Like, what's their long-term plan?
Well, you asked a key question, which I did not touch on during my presentation, but the ultimate genetic transplantation in this patient is to get a liver transplant. So by replacing the liver, you cure them because you're giving them a normal liver with a normal ATP transport protein that's going to excrete all of that copper. So the only way to get off Triantine and zinc, which is my magic dual combo, is to get a liver transplant. But of course, we're not going to offer a transplant unless they have cirrhosis, liver failure, or acute fulminant Wilson disease. And of course, you wouldn't offer a liver transplant to somebody who didn't fit standard criteria with a MELD score typically over 20 to 25. But you get a liver transplant, you're transplanting great genes into the patient, then the patient gets decoppered. One of the problems, though, with liver transplant, especially for chronic Wilson disease, is a lot of the neuropsychiatric damage is permanent. It's hard to get people to get all the way back to normal because that copper overload's been in the brain for years. And I really believe it causes a certain level of neurodestruction. So you definitely want to make this diagnosis early. And if they have cirrhosis and liver failure, try to get them to transplant earlier. While they're on the transplant list with chronic liver disease, they should be getting decoppered during that time. I think those are very important steps.
Great. Thank you so much, Dr. Gish. Well, I don't see any further questions. So I'd like to just thank you again very much for this very informative talk. And I hope that everybody took something away from this discussion on Wilson's disease. And I also want to thank the sponsors for allowing this to be possible. And of course, again, thank you, Dr. Gish, for this wonderful presentation. So that concludes.
My thanks to Liver Coalition.
Great, and the Liver Coalition as well. Thank you again, everyone.